We are talking mainly about endometriosis and chronic pain today. First, I would start with saying, what is pain? Yeah. So, International Association of Study of Pain definition, it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So the main words is sensory and emotional. So it is a very subjective feeling. If as a pain consultant, somebody asks me what is pain, I would say pain is whatever a sufferer says. Because it is a subjective experience, it cannot be measured in units and every individual react to it very differently. Pain is protective, but only when it is in acute setting. When we call it acute pain, when you have an injury, trauma, or a surgery, and healing occurs from that and pain subsides. So that is what we normally expect, that you have a pain for a reason, and once the stimulus is gone, then the pain subsides. And it is very confusing when pain continues. After injury is healed or initial cause is subsided. Usually, if the pain lasts for more than 3 months, then we classify it as a chronic pain. The most important thing about chronic pain, it has no more protective function. So in the condition endometriosis, the reported incidence of endometriosis is 10% in reproductive age group. And it is a condition where endometrial tissue goes outside of the uterus lining. And during reproductive age, women and those assigned at birth as a woman, body prepares for pregnancy each month. And this occurs in 2 phases. First phase is maturation of egg in the ovary. And at the same time, uterus lining builds up to facilitate the implantation of fertilized egg. However, in phase 2, if the cycle is without pregnancy, the layer in the uterus breaks down and results in menstruation. There are several theories of endometriosis, but the most accepted theory is it is caused by retrograde menstruation. And what does that mean is when the menstrual flow moves in a wrong direction, and if it is severe, it can lead to endometriosis. So when the menstrual flow is in a wrong direction, the endometrium arrives in the abdominal cavity through the fallopian tubes, and it adheres to the peritoneal lining and develops into endometriosis lesion. And these lesions can affect ovaries, it can affect the fallopian tubes, it can affect the uterine segments and attachments, so any adjacent structures, appendix, and sigmoid colon. Sometimes it can be even on the diaphragm and in the lungs. So how does the peritoneal structures react to it? Because of the unwanted tissue in the unwanted place, it is that it develops a peritoneal and endometriotic inflammatory response. That's a response in the inflammation in the pelvis as well as in the endometriotic foci. And this is as a result of release of chemical soup at the site of endometriotic tissue. And there sometimes occurs is the scarring at the site of endometriosis tissue. And when that happens, this structure adjacent to that endometric tissue stick to each other and causing fibrotic thickening adhesions, and further accumulation of menstrual blood in the endometriotic implants. This causes painful traction and causes more pain. The other thing that happens is because of the chemical chronic inflammation, there is stimulation of the growth factor, and that induces the growth of the nerves, you can see there, into the endometriotic foci, and that results in neurogenic inflammation. What does that mean is inflammation of the nerves. And that changes the dorsal horn, that causes changes in the dorsal horn of the spinal cord, leading to central sensitization. In addition to that, you can see these nerve endings. Those are the C and A delta nerve fibers we call. Those are the nerve fibers which are responsible for carrying the pain information to the brain through the spinal cord. So because of all the processes that's going on in this region, there is increase in amount as well as density of these nerve fibers into the endometriotic foci. And hence, that further enhances the information of pain going to the brain, and we experience more pain. So what are the symptoms commonly experienced? Pain and fatigue are the most common, and patient experience severe pain or cramping during menses. There can be cyclical or non-cyclical pelvic pain, ovulation pain. Also, bowel movements and bladder can be painful, and also urinary and bowel changes occur. And these symptoms of bowel and bladder, they can occur during or before menstruation. Pain with the sexual intercourse is very common finding or symptom in the patients. Chronic fatigue, it is due to the multiple reasons, which I'll discuss this in the further slide as a separate thing. Infertility is very common. There are other symptoms depending on if the endometriosis spread to the other parts of the body, such as chest, then person may feel pleuritic chest pain, hemoptysis, that is blood in the cough, and these will be cyclical changes that a person would experience. Headache and pain in the surgical scars. Endometriosis affect negatively in multiple areas of patients' lives. Pain is not the only issue, but the implications of pain, it affects day-to-day activities, social activities, physical activities, mood and emotions, relationship with family or partners, and work or school. So it causes significant burden of disease on a person who is suffering from the condition. And these are some of the quotes from one of the study that was conducted. It was a qualitative interview of the patients suffering from endometriosis and how they describe the effect of the fatigue and pain that they have. So normally how the pain is processed, there is always either injury or whatever the stimulus.
Hi, Bharati.
Yes. Hello? Can you hear me?
Yeah, we can hear you.
Okay, because I heard Emma shouting. Okay, so whenever there is an injury, there is a transmission of pain from the site of injury to the spinal cord to the brain. And the information is not just going to the center of pain, but it is also involved the center of memory and emotion in the brain. So there is a pathway which takes the impulses to the brain, the information is processed. Any positive emotion, positive memory will have impact in reducing the output from the brain and the way you feel the pain. So there is an ascending pathway and then the information which is coming descending pathway. So it's not only the input to the brain, but it's the output that decides how much pain a person feels. So we just discussed in the previous slide about the pathophysiological changes that happen at the site of endometriosis. There is increased number of nerve fibers that carry pain information to the brain, and therefore the ascending pathway is overactive. And when the pain continues for long time, the chemical response is not switched off, and more sensitization occurs at the periphery, and it causes more and more sensitization at the central level. At the same time, there is cognitive and emotional sensitization, sensory and motor conflict, and as we see the implications of pain on day-to-day life and all aspects of person's life, there is no positive emotions or memories that would reduce this output, and the whole system is malfunctioning. That increases the pain even more. Endometriosis and fatigue. The fatigue in the endometriosis is multifactorial. And it is a frequent symptom of inflammatory disease, suggesting that immune system with elevated cytokine could play a role. Always when you see the diagnosis from the time of first symptom and the diagnosis, it's quite delayed. Between 2.5 to 7 years is the time when people get actual diagnosis. And that causes the suffering, the burden of the disease, and intensifying pain. When pain is increasing, you suffer from insomnia because brain is constantly in flight and fight response that keeps you awake. So not just endometriosis, any pain pain due to any reason affects your sleep. And all this in combination causes depression and chronic higher level of stress. Higher stress levels, constant high stress levels can cause adrenal fatigue. When we talk about adrenal fatigue, there is when during higher stress level, the hypothalamic pituitary adrenal axis is altered in patient with endometriosis. Because when chronically exposed to high stress can result in adrenaline fatigue and low cortisol level. And the cortisol is a hormone which helps body to cope with the stress. So if the level is low, it reduces the coping, which can even contribute to increase in pain and fatigue, both. There is one large multi-center case control study which was done between 2010 and 2016. They recruited patients from hospital, private practice in Switzerland, Germany, and Austria. The data is collected from 1,120 women, out of which 560 of them with endometriosis and 560 control. Main results showed that frequent fatigue was experienced by majority of patients diagnosed with endometriosis, that is 50.7% versus 22.4% in control group. And fatigue in endometriosis was associated with insomnia, depression, pain, occupational stress. It was independent of age, time since first diagnosis, and stage of the disease. So what is the role of the pain clinic? We, as I said in the beginning, that patients are referred to pelvic pain service via monthly multidisciplinary endometriosis meeting. So the patient would have either confirmed diagnosis of endometriosis or might have even had few laparoscopic before coming to the pain team. The clinic is multidisciplinary, which is recommended by all the guidelines, which involves a pain consultant, specialist pelvic physiotherapist, and specialist nurse for the first appointment. And we spend 80 minutes for the first appointment. During this time, we discuss symptoms, pain history, past medical and surgical history. Most important is exploring the patient expectation, because it's a shared decision making, consideration of patient age, what plans they have for pregnancy, are they considering, or there is a plan for IVF ongoing at the time when we are seeing them, because that completely changes the management that we offer. If the pain, if there is such, it is suggestive that there may be pain unrelated to the endometriosis, then whether needs investigating further, then we'll order further investigation to rule out or to confirm other causes of pain. Management, surgical or conservative. In conservative management, it's mainly, again, depends on, the severity of the pain, duration of the pain, whether the pain is intermittent or whether it's constant, how it is interfering with daily life, and other plans that we just talked about. All the pharmacological and surgical means are the most used to treat endometriosis, but both have its own side effects. So in medication, when we discuss if the pain is mild to moderate, non-steroidals such as ibuprofen, naproxen, or diclofenac, and simple analgesics like paracetamol are useful. And then tranexamic acid, mefenamic acid is prescribed by usually surgical team for the bleeding. Hormonal treatment are usually given and suggested by the surgical team. Patient may have gone through all the hormonal treatment by the time they come to pain clinic. Neuropathic medications, which may be either antidepressants or anti-epileptic. We use it very cautiously if the clinical history suggests that it's a nerve-related pain and it is constant everyday pain, then it makes more sense to use those medications. The reason is neuropathic medications, they do not work if you don't take it every day. So either you have to take it every day or person should not take it, because you don't get the benefit, but you'll get the side effects of it. And it always takes a minimum of 2 weeks to 4 weeks to see the difference with the pain with the neuropathic medication. It's not like ibuprofen or paracetamol or morphine. When you take, you feel straight away better. Opioid such as codeine, tramadol, morphine, they are not good, because usually endometriosis pain, but when we see patients in chronic pain clinic, it is a chronic condition. And opioid has a tendency for dependence, tolerance. Tolerance, that means the longer you take, the effectiveness of that dose wears off, and then you have to increase the dose. And there is a limit how much we can go up with the opioids. And then it comes to the stage when the benefit is lost, but sometimes with opioid, you can get the reverse effect, that it causes more pain rather than giving a benefit. So opioid is good only in acute setting or very intermittent flare-ups, then it is more useful, but not for something to take everyday pain relief. Sometimes we do offer interventions, and it depends on examination, clinical findings, if there is nerve entrapment or spinal pathology or that suggests nerve irritation, or it can be adhesions or scarring can cause nerve tethering as well. And there are certain pain nerve entrapment that can be addressed with the injection. The advantage is if it works, then patient come off the medications, and if it lasts for longer than 6 months or a year, then that's what can be repeated as well. Then coming to the non-medical management, that is either physical therapy. Physiotherapy is indicated mainly when there is high pelvic floor tone and issues with the sex because of pain. And we do see good benefit from the physiotherapy, pelvic physiotherapy in that context. There is moderate evidence reported in the guidelines as well. Psychological therapy and pain management program, my colleague, Dr. Zoey Malpus, is going to talk in detail about it. So I'm not going to mention here, but that is what you need as a long-term strategy to manage pain. Living with chronic condition is not easy. There will be days when you have a good days and bad days, and to cope better with the bad days, you need a long-term strategy. And that's what we achieve from psychological therapy and pain management program. There are different guidelines. The recent one updated is endometriosis guideline of European Society of Human Reproduction and Embryology in 2022. It recommends that clinicians should discuss non-medical strategies to address quality of life and psychological well-being in patients managing symptoms of endometriosis. However, they do not recommend any specific non-medical intervention, and further research is needed. But there is recently a lot of literature which is published, and patient that we see in pain clinic, they do mention about different methods like acupuncture, meditation, relaxation techniques, they exercise, everything that they find it beneficial. Then European Association of Urology Guidelines 2018 and NICE Guidance 2017 strongly recommend the provision of multidisciplinary approach to pain management of chronic pelvic pain. And it is important that women with endometriosis have options addressing psychological, sexual, and physical factors to improve quality of life, even when pain cannot be reduced completely, but it is to improve the quality of life. And you do say that some of the treatment options which are non-medical, not necessarily the pain is reduced, but the quality of life improvement is seen. So these are just the references. Thank you very much. I'll stop sharing now, and I can turn my camera on as well. So we can take questions at the end, if that's okay, when Zoe finishes, because then she will, in her presentation, she will cover some of the questions as well.
Perfect. Thank you, Bharati.
Okay, well, thank you very much for the opportunity to talk to everybody this evening. I'd like to talk about the part of the pathway that Bharati has very kindly left for me to explain to you. Thank you. I'd like to talk about the psychological groups that we've been developing at Wythenshawe Hospital. And I should maybe tell you just a little bit about me. I've been a pain psychologist for getting on for 20 years now, scarily. I used to work at Salford Hospital for about 5 years, and I've been at Wythenshawe Hospital working with Dr. Vyawahare for the last, gosh, is it about 13, 14 years? Bharati?
Yes, it is.
Longer than I care to think, but of course every day has been a pleasure, Bharati, hasn't it?
It is, yeah.
Okay, so I would like to talk give you a quick overview here, I want to talk about what a normal psychological reaction is to being stuck with pelvic pain that can't be cured. Thinking about what are the bodily reactions that are part of that normal psychological reaction to pain as well. And then I want to propose this compassion-focused therapy that's a relatively new psychological approach to promote soothing stress, and stress really winds pain up, but also striving. And I meet so many really driven ladies who've got like really high standards, who keep forcing themselves to keep going even when they're in agony. And I think that can be another thing that we really need to help people to be kinder to themselves with, but I'll come back to that. But all of this is just a background to why at Manchester we've started to pilot these compassion focused therapy groups for ladies with pelvic pain, and show just a few of those outcomes, if that's okay. But I'm hoping you can see all of this on your screen. What is a normal psychological reaction to being stuck with pelvic pain? Well, I guess it's normal to get really frustrated because you can't do that long to-do list of things that you want to do. It's normal to get really scared as well when you don't know how bad your pain's going to get, or kind of if it's ever going to end. And I guess the longer it goes on, unfortunately, the more normal it is to find that your mood really starts to dip and you can get really down because the pain stops you doing the things that make you feel proud of yourself. So I guess the longer it goes on, the more likely it is for that to become a problem in its own right, even though it's a totally normal reaction to living with pain. So just a little bit about stress, because this is a tried and tested part of all sorts of chronic pain that we understand. There's been, oh gosh, over 50 years of research that looks at how pain is an alarm. It's like having a burglar alarm going off in your head, and your body gets ready for that burglar. You get pumped up into that fight or flight. And you'll see in this picture, pretty much every part of your body, every organ has got part of this stress system that goes to it that makes it go faster and work harder. But the good news is that nature's given us the answer to this. There's an equal and opposite nerve that calms and soothes and slows it down. I'm so sorry, there's a kitten complaining at my door. I'm just going to let him in, otherwise he'll moan louder and louder. Yes, so nature, and that includes kittens actually, apart from when they're knocking on your door, crying on your door. So this equal and opposite part of your nervous system calms and soothes this reaction to pain. And so a lot of kind of our psychological approaches are aimed at trying to tap into that kind of your body's natural system that helps calm and soothe some of that normal response to pain. But I guess something that's new that we've only really started to think about in the last maybe 10 years or so is this striving response to pain as well. Because I meet lots of people who say, I'm not going to give in to my pain. I'm still going to do that long list of things that I want to do. And they force themselves to keep going until they collapse. I guess in the short term, you get that buzz, that sense of pride and pleasure because you're doing the things you want to do. But the more you drive yourself, the more likely you are to become exhausted. And I noticed that a few people have mentioned fatigue in the questions that they've asked about. Some of that fatigue is about not being kind to yourself. It's about forcing yourself to keep going through gritty teeth, when actually it might make more sense to give yourself kind of permission to slow down just a bit so that you're strong enough to keep going the next day. And the good news is, again, nature's given us the answer to kind of combat this striving. And the idea is that all mammals have this urge we have from when we're born to form secure attachments with other living mammals, or nature actually. I'm going to say a bit more about that. If we think about, you know, those nature programs where we see those cute little baby turtles that hatch out of the eggs and they try to make it down to the water, unfortunately most of them don't make it. Apparently for every 3,000 eggs that hatch, only one of them survives to adulthood. So a mother turtle's kind of evolutionary strategies lay more eggs. But if you go up the evolutionary ladder, by the time we get to chimpanzees, for example, and I know everyone at home was going, looking at that cute little baby chimpanzee, weren't they? That little chimpanzee is going to spend about 8 years securely attached to the mother. And in their central nervous system, there's a whole hardwired system for making them want to stay close to the mums and for the mum to want to keep that baby close to them. And we have those same kind of hormones hardwired into our system. And that's part of our soothing system that can calm that striving urge. So if we think about this cute little lady here, how long is she going to spend securely attached to her mum? A long time, isn't it? So what does all of this mean? Well, what it means is that humans are social animals, and we have this much longer childhood than those little baby turtles. So we're hardwired to want to stay close to our parents. So we form these secure attachments. And the three things that happen inside our nervous system that underlie that are oxytocin, and that's that warm flush you get in your chest when you feel close to someone. And would you believe endogenous opioid? So that's nature's morphine, and you don't get constipation from nature's morphine. And also that vagus nerve, that was that soothing part of our nervous system that I showed before in that picture. So the idea is that when we feel close to other human beings, we're much more able to be compassionate because we're feeling safe and we're not stressed or striving. What does all of this mean in terms of what we can do to help treat it then? Well, this guy down here in the mid-90s developed this new form of psychological therapy called compassion-focused therapy. And it draws upon evolutionary principles, so understanding how our brains and nervous systems have developed, but also some Buddhist principles that help people ought to be socially towards other people. And the idea that this is a non-judgmental approach, that it's not our fault that we just find ourselves here in this tricky body at this point in time, but it is our problem because we've got this ancient body that's hardwired for threat and for striving. Threat because our ancestors lived in dangerous times, and striving because there wasn't always plenty of food around. So we would be booming and busting trying to gather as much food as possible for noticing scarce resources. And the other bit that I really like about this approach is that we actually have this duty to ourselves, this responsibility to act to prevent that suffering. And we're normally really skilled at preventing the suffering others, but I put it to you that actually it's our own suffering that we should be taking steps to avoid. So in compassion-focused therapy, we look at how all mammals have three competing motivational states. The first one here is our threat system, and that's that stress system that's hardwired to avoid danger or to fight it. We have our striving system, that's our drive, that pleasure seeking, resource seeking. But we also have this equally sized soothing system for managing distress and promoting bonding. And we need each of these three systems, but ideally the three should be balancing each other out. And unfortunately in pain, our threat system is huge because pain is like that burglar alarm. And actually, if our main coping strategy is to force ourselves to keep going, to push on through, then that blue circle is huge as well. So what does this mean? Well, it's not our fault. We've got this hardwired into our old brains, but it is our problem because we have to cope with the consequences every day. So at Manchester, what have we done about this? Well, we developed compassion-focused therapy for pain management groups and been running them since 2015. It's an 8-week group that runs for 3 hours a week with a half-hour break in the middle, I should say. And we've run 28 of them now. Most of those have been people with different diagnoses in the group. But actually, we've been consistently getting feedback from the people with pelvic pain that they wanted a group of their own. It would be much better if it was only other people with pelvic pain. And we trialled one last year and we got some really great results. So first of all, I'm going to show you how people do with pelvic pain doing the general group. And they do well. Their depression improves by about 1/3, their anxiety by about 1/5. And they do develop some of these compassion-based skills. So their self-compassion, for example, is 41% better at the end of the group. That's in the mixed group. If we look at the pelvic pain only group, well, the anxiety and the depression scores make similar improvements, but wow, people are much more able to develop their self-compassion skills 106% better after the end of those 8 weeks. And these are some of the reasons why people say, now I don't know whether you can see that on your screen. Let me just move some of these down. So for example, here we've got people saying, I felt really glad to be in a group of women with similar experiences to me. I felt safer to share my feelings and experiences. The shared aspect of pelvic pain, I think, was a really helpful element of cohesion and sharing understanding. I mean, you can read those quotes for yourself, can't you? But I just really want to emphasise how much those shared aspects are. And I love this one particularly. It's helped me at a stage when deep down I felt I might be beyond help. So I think it has something to offer everyone living with the consequences of pain. So conclusions. So here at kind of Manchester Foundation Trust, we found that the CFT group is effective for people with pelvic pain, whether they're in those mixed groups or the pelvic only group, but the patient feedback consistent is that they want specific pelvic groups. So we're due to start our next pelvic specific group again next March. Now, I've included some links here, and we've actually put some videos on our Trust website. I don't know whether you're interested in looking at some of the exercises, for example, that we do in our compassion-focused therapy groups. We've got videos on there from our physios at the pain clinic, and also the psychologists have uploaded. And we've actually been able to publish 3 papers with our outcomes of our compassion-focused therapy groups. So I'd be really keen to hear what you all think about that, and I'm keen to hear your questions. So I shall stop sharing there and come back to the main group. And that is my cat. This is Dirk, by the way, folks. He's a demanding cat.
Hi, Dirk. Thank you, Zoe. That was so informative, and I love the cameo from Dirk. Well, we've had like loads of questions come in through the Q&A function. I'm going to start off first with a pre-sent question. My first one is, can painkillers wearing off quickly after prolonged use? Actually, sorry, that's not really said very well. It's probably me just like kind of trying to condense it. So can painkillers wear off quickly after prolonged use? And if so, what's the best way to take painkillers for endometriosis?
It's not every painkiller, but if you are using opioid, that's why I said it's not recommended, because when you use it for a long time, your body gets used to it, dependent on it, and develops tolerance. So that happens with opioid like codeine, tramadol, morphine, but not with other painkillers. But with the chronic pain, for the reasons that we discussed, the pathophysiology, with longer duration, the pain can feel more intense, and medication is not the only option, because medication will only work on the receptors in the body, but it's not going to have a significant impact on the other issues that we discuss, effect on activities and social life and personal life, that burden that need to be addressed, the way we think about ourselves. So that's very common, that we feel when you're taking it for a long time, it feels like the effect is wearing off, but it's not true for all drugs. Yeah.
Thank you. And someone's asked, how they can access a pain clinic, and how do they find out if there's one at their local hospital?
First of all, important is to have the gynecology referral and the diagnosis, because some of the treatment that they offer is disease modifying. So if that works, then you may not have to see the pain clinic. And that's why we see patients seen by the gynecologist has a confirmed diagnosis, and they have done the initial management with the patient, and that is not been effective. Pain is still persistent. Pelvic pain clinics are not nationally available to everyone. There are only one in the London, UCL, and then Oxford and Manchester.
Fantastic. Thank you. Okay. How can I deal with endometriosis pain without painkillers every day?
I think there are alternative therapies like TENS, exercising, that patient do say that it is effective, and the psychological therapies that Zoey mentioned. CBT is useful, but all these, as per the guidance, and when you look into the research, this all needs a lot of research. But it does, from our experience and the patient's experience, we do see that some patients do get good benefit with TENS, acupuncture, physical exercises.
Can I add to that? I'm just thinking, you know, the videos on our website. So if people wanted to have a look at kind of the sorts of relaxation exercises, breathing exercises, gentle stretches that our pain team would be recommending, it's a good place to start. That's enough for some people, whereas for other people, you might need to go and see a professional in your own right and get an assessment, and then they can offer you kind of individually tailored something that's exactly right for you. But people who wanted to find out more about this approach, we've got those videos on our website. Dr. Vyawahare, you recorded our pain information video on there, didn't you?
Yes, yes.
Yeah.
And developing coping strategies in long term, because that's
Yeah.
going to help you more. You'll always have good days and bad days. So.
Amazing. Thank you. Thank you for signposting to those videos. I'm sure they'll be very helpful. So does pain reduce after a laparoscopy?
It is when we see patients in the pain clinic, or the treatment is very individualized, because there are so many factors that comes to play in terms of pain. So some patients do improve, but there is also a recurrence rate of 50% with the pain recurring and the endometriosis recurring. So every individual is different. There is no set pattern to it. So, and even if it worked, the pain may still recur.
Thank you. And what medication is effective to manage pain when you're not bleeding? This person said, for example, not tranexamic acid. Hope I pronounced that right.
Yeah, I think the tranexamic acid is more for reducing bleeding. Some antispasmodic medications such as Buscopan, because you get spasmodic pain in the muscles with the menstruation. So Buscopan may be an useful medication to take as required, because you can take it as required. Non-steroidal medication, which are maybe ibuprofen, diclofenac, naproxen, are effective. And neuropathic medication, but that is based on the assessment of the patient and whether they have a component of nerve pain, because every patient is different and it's a very individual plan that we make.
Fantastic, thank you. And my next question is, are these kind of groups going to be UK wide? So I think they're talking about the compassion therapy groups.
Well, I think quite a few pain clinics are starting to develop the general compassion focused therapy group for pain management now. I think quite a few people have been really pleased with the sort of work that we've been publishing out there, been contacted by lots of other pain clinics across the UK. I think we're probably the first one to be using it for pelvic pain only groups, but I definitely think this approach could be helpful. You saw the results for people who are in the group with like lots of different diagnoses. That was still helpful. It was just that actually in the group with other people often said they felt like they had more of an invisible pain because they hadn't had a car crash or something like that. So it was more difficult for them to share the impact of their pain in a group with people with, I don't know, broken backs or something. So actually, hopefully it'll roll out in the future, but yeah.
Thank you, Zoe. Is brain fog normal with endometriosis and chronic pain?
Yeah, patients do report it it's a very common theme with pain, fatigue and brain fog, yeah.
Bharati, I don't know if you can see this, Zoe. Like, I feel like your screen looks like it's being possessed and it's flashing images of me and you.
Yeah, it did flash.
And I'm expecting like a voice
to come in. Yeah. It stopped.
Okay, amazing. So my next question is, oh, I'm so sorry. What was everyone finished answering that question? I don't want to move on if.
Yes.
Okay. So this person has said they were advised to have the coil and the mini pill, which should help ease pain. But they're scared about what happens when they want to start a family, and if they start a family and they come off of the coil and the mini pill, will they be in pain constantly, or is there an alternative to try whilst? trying?
I think when you come off coil or pills, you may consider trialing other pain medications. And alternative therapy is useful because when you want to go and start family, obviously you don't want to be on a medication which can be harmful or transferred to the baby. Yeah, it's just maybe that's the time when you can again, develop the long-term managing strategies beforehand, before the pain, and have a more control on the pain than pain controlling you.
Thank you. I'm going to add to those non-pharmacological strategies, aren't they? And some of them are psychological, so managing stress, but also managing striving. I meet so many determined ladies that keep going when really they need to stop and rest and look after themselves, not everybody else in their life. And I guess as well as the psychological, there are things like the TENS machine, there are hot water bottles, there are lots of other non-pharmacological strategies as well.
Yeah, sorry, when you mentioned that in your talk about like people just trying to do everything and then some, I was just like, that sounds so familiar from what I hear people saying, and you're just like, take a break, but sometimes like they can't, and it's sometimes it's a vicious cycle. So it's definitely something to highlight. And so what can you do if you feel that your GP isn't taking you seriously regarding chronic pain?
It's very difficult, isn't it? It's the education of the GPs about the condition. And that's why I think improving awareness amongst the professionals, maybe speak to some different GP. There will be someone who is better than the others in understanding the situation.
Yeah, seeking another opinion. It's always an option.
Yeah, maybe a female GP.
And my next question is, so you mentioned acupuncture before. Are there any side effects with this? So someone's being referred for nerve damage post-surgery.
So the question is whether the post-surgical nerve damage and acupuncture, is it?
So they're being referred for acupuncture for nerve damage post-surgery, which happened post-surgery, and they want to know if there's any side effects with acupuncture.
Normally, there are no side effects as such with acupuncture. No.
Thank you.
But even acupuncture is not indicated if you're thinking you're pregnant.
And also from the pre-sent questions, I've got a question is there any evidence that acupuncture or other complementary treatments work?
Obviously, there is a need for gathering more evidence and research, but in clinical practice, we see some patients, it is effective. It's again very individual, but we need to have a proper research setup for that.
And do you have to have tried all hormonal treatments to have access to a pain clinic?
No. You cannot access it early. Maybe your gynecologist can refer you side by side.
Okay. Can the Mirena coil to manage endometriosis increase sciatica pain? Is there any correlation between endometriosis and sciatica?
Coil itself shouldn't have any, it is not the cause for sciatica pain. But if you have endometriosis, sometimes you can find it close to the sciatic nerve, the deposits of it, or implantation of it, or if you have a spinal endometriosis as well, sometimes that can irritate the spinal nerve root where the sciatic nerve originates from, then you can get a sciatic-like pain, or it can be completely unrelated to the endometriosis and that's where we look into, like, it is a diagnosis and differentiating whether this pain is endometriosis or is it coming from spine, not necessarily because of the spinal endometriosis, but there are maybe other spinal reasons that can contribute to the pain and needs investigating further. Then we'll do a scan to look into the spine and take action and management based on that.
All right, thank you. And can one still have endometriosis after a hysterectomy and endometriosis excision surgery?
There is a possibility. Yeah.
Okay. I feel like you've covered this. So maybe there's more to add for this one, but what are the most effective ways of managing fatigue from endometriosis?
Pacing.
Yeah.
But the psychological barriers to pacing are huge. People tell me they feel lazy or they feel like a failure if not rushing around doing everything for everyone else, but then they end up crashing and burning and having to rest because they're wiped out, and then they still feel like a failure and feeling guilty and lazy. So it's a vicious circle anyway.
Yeah.
If people can give themselves permission to do a bit and stop and do a bit more and stop, you actually get more done that way. And you're not as wiped out and exhausted afterwards. But it's the psychology of that that's the hardest part. People know the theory of it, but actually stopping once you get started is harder than getting started.
And I think that kind of leads nicely to so our next question is, how do you manage going back to work with chronic pain, especially in managing a physically demanding job? And if either of you have any examples of patients who've gone back to work in a I know everyone's different, but like a controlled way, I'd be happy for you to share.
Yeah, I think you can always ask for phased return at workplace or making adjustment to your duties. The job which is less physical or less working hours. So there are a lot of things that you can work with occupational therapists and the department to make adjustment at workplace.
I think the hardest part is asking for those adjustments, because often people try to struggle on by their own, or they go back to work on full-time hours thinking that's the quickest way to get back to normal, but it's often the quickest way to be off sick, I'm afraid, and that just fuels the problem.
Is fibromyalgia linked to endometriosis?
Not necessarily, but because we see so many fibromyalgia patients, but they're not all of them have endometriosis, or neither all the endometriosis patients have fibromyalgia. But fibromyalgia is again a diagnosis of exclusion, generalized fatigue, pain, which you can, it is very fine line to say whether a person has a fibromyalgia or is it just the chronic fatigue from the condition itself.
Someone finds that heat increases their pain. Is this normal?
Some people do find it. It's not common. Usually heat helps, but there are some patients that heat makes it worse. That's why I said, it's very individual plan that we have to make. Every patient is very different in terms of response to treatments.
Okay.
Can I just pick up on a few people have asked us to share the links to, our videos. I've answered them those questions, so they're in the answered pile. I don't know if people watching can see the answers because I pasted the link in there, if that's okay. Just so
Hold
that
on one moment. What I can do, if people can't see the answers, I can share the link after tomorrow when I send the feedback survey. So hold on, let me just make sure I have these as well. And I'll just pop it somewhere. Okay, perfect. So my next question is, Okay, so does exercise make fatigue worse or better?
Back to pacing, isn't it? It depends how much exercise and how often.
And there is a literature says that actually the activity improves pain and fatigue, but it has to done in a right amount. So it's a balance between not being doing anything and active, and it's a gradual build up on the activities, which helps in long term.
Thank you.
And I'm going to say hand in hand with that, it's about managing that stress and that striving response. Because if you're doing exercise terrified it's going to flare your endo, then actually there's a good chance you're going to be exercising in an unhelpful way that may cause all sorts of spasms. Equally, if you're doing it in a striving way and doing more than you should be doing, you're just going to trigger all sorts of problems as well. It's trying to find that sweet spot and being satisfied with that sweet spot that's the hardest bit.